Hi, I'm Alex. My chosen clinical technique will be subcutaneous digital nerve blocks. For this presentation, I'll briefly explain the procedure, indications, contraindications, benefits, a brief demonstration, and finally, the variant settings the procedure is used in or could be used in. A digital nerve block is a risk-adverse procedure that provides excellent analgesia and is a powerful tool when used as part of a multimodal pain relief plan. The analgesia with a subcutaneous method is achieved by injection of a small amount of lidocaine into the base of the affected finger's subcutaneous layer. The lidocaine isn't injected to the nerve, rather the anesthetic bolus slowly diffuses through the interstitial space, which bathes the four dorsal and palmar nerves, causing the membrane potential of the neurons to stabilize through ionic blockade. This means that the signals are blocked because the neurons aren't able to propagate any action potentials, which the brain would then interpret as a painful stimulus. The indications include analgesia for a range of traumatic conditions, surgical procedures, or post-operatively, and including manipulation of digits. Contraindications include anaphylaxis to the anesthetic agent, severe vascular compromise to the digit, especially with tumescent blocks, which may worsen the vascular compromise, and infection at the site of injection. So what are the benefits? In short, analgesia is achieved within 5 to 10 minutes of injection and has a duration of 30 to 40 minutes with lidocaine of complete or at least partial nerve blockade. The reliance to resort to higher doses of opioid medications is reduced, which is usually associated with higher risk of unwanted side effects like nausea, vomiting, dizziness, altered conscious states, and reduced respiratory effort, leading to unsafe conditions for the patient. So by using digital blocks, we effectively limit these situations occurring. The procedure itself has an equivalent infection risk to performing any other intramuscular or subcutaneous injection once the skin's prepared correctly. The injection site also contains no major neurovascular structures, minimizing the risk of damage. Lidocaine has a wide margin of safety, with toxicity levels not typically seen until 3 milligrams per kilogram, and adverse events only occur in less than 0.05% of cases. Subcutaneous digital blocks are the easiest block method to learn, don't require surgical asepsis to achieve, meaning they can be done almost anywhere, and due to their simplicity, place little cognitive pressure on the practitioner. Lastly, it's extremely cost-effective, usually costing under $10 per procedure. Onto the procedure itself. Prepare the skin site, which will be at the proximal skin crease at the base of the palmar aspect of the injured finger, by swabbing the skin with a prep pad for 30 seconds and allow it to dry for 30 seconds. Draw up lidocaine 1% into a syringe and attach a 25 gauge needle. Pinch together the skin distal to the crease and insert the needle at a 90-degree angle until the needle passes through the layers of the dermis. Resistance should be felt as the needle interacts with the flexor tendon, but be wary not to pierce this. Aspirate to ensure the needle is not within a vessel, then slowly, over 60 seconds, inject between 2 to 4 ml of lidocaine, equivalent to 20 to 40 milligrams, until tumescence, which is indicated by a circumferential distension of the skin. Once complete, withdraw the needle, dispose appropriately, and very gently massage the site of injection into the tissues. Record, as always, and expect analgesias within 5 minutes. If there's no effect, wait another 5 minutes and be alert for hypersensitivity reactions. Digital blocks are currently performed by primary health service providers within general practices or secondary health services like specialist elective, oncology, plastics, and pain teams, and in tertiary care centres such as hospital surgical suites and within emergency departments. So what about pre-hospital care? Pre-hospital care provided by paramedics working for a state service or private entities are yet to fully embrace nerve blocks as a mainstay of their pain management guidelines. The aforementioned evidence, specifically efficacy, safety, simplicity, and cost-effectiveness, mean that implementation would be seamless, especially since many services, including Ambulance Victoria, already carry the equipment and anaesthetic needed, meaning only training is required to implement this into practice. This training would be easy to integrate due to the similarity to intramuscular injections, which are already done in pre-hospital widely. This would provide paramedics, especially in rural areas, much needed tool to provide safe and effective analgesia to people across the country. Thank you.